tonight.
It wasn't like ordinary pain. It was unbearable.
I did not have any strength in my hand at all. I was having pain up through my arm.
She couldn't hold a glass. She had to drink with two hands.
It was kind of frustrating.
An ABC 27 special presentation.
I could not do anything. I couldn't cook. I couldn't read because I couldn't concentrate. I had lost my whole life.
Penn State Hershey Spine Center presents We've Got Your Back. Brought to you by Penn State Milton S. Hershey Medical Center.
Good evening, I'm Chuck Rhodes. Severe back pain can be very debilitating. An innocent twist of the body can create big problems, I can tell you that firsthand, but I'm not the only one. Statistics show that 85% of the population in the U.S. will suffer from back or neck pain at some point in their lives. Back pain is the leading cause of disability in Americans under 45 years old. Tonight, specialists from Penn State Hershey Spine Center are in the ABC 27 call center to answer your questions. Call the number on the bottom of the screen, or you can email your question during the show to questions27@abc27.com. Dr. Everett Hills will answer your emails throughout tonight's show. And remember, all calls and emails are confidential, and they remain that way. And we begin tonight with one of those stories, and here's Deborah Pinkerton to open it up. Deborah?
Thanks, Chuck. A Lebanon County woman had pain and weakness in her right hand. She was shocked to find out where it was coming from. 51-year-old Sally Bachman enjoys painting. Her latest project is a gift for her son.
He's Army National Guard, so he wanted nightstands that have the American flag painted on the top.
A steady hand is needed to paint the stars and stripes, something Sally didn't have a year ago.
There's no way I could have done any kind of even semi-straight lines because my hands shook so badly.
And that's not all.
I did not have any strength in my hand at all. I was having pain in through here, up through my arm.
It came to a point where she couldn't hold a glass, and she had to drink with two hands.
It was kind of frustrating. You would think you would have a hold of something, and next thing you wouldn't have a hold of it, or you'd go to pick it up and you couldn't get the grip on it to pick it up.
I'd be in the basement or somewhere else, and I'd hear her say something, like hear something drop, and she said, well, I just dropped the glass or dropped the milk or something because she lost her grip.
These were minor accidents compared to what happened on Valentine's Day.
I was coming home from work and I went back into our driveway. I was, of course, with the one hand kind of like leaning and looking in my mirrors and things, and I didn't even realize that I didn't have a hold of the steering wheel until I felt the thump and that I hit his truck, and I was like, oh my gosh.
She came in the door crying. She says, I backed into your truck. I don't know, I'm so upset.
I'm saying, aren't you mad? And he's, why should I be mad?
I said, did you do it on purpose? No. Are you hurt? No. Well, sit down, let's eat. It's an accident. Accidents happen.
He's a sweetheart and is not upset with me for denting his truck.
After that incident, Sally went to her family doctor.
First, I examined her to try to figure out what was going on. She actually did have significant weakness of her hands, mostly the right hand. My recommendation was to get an EMG nerve conduction test to figure out where the damage was occurring in the nerve that goes into the hand.
We did an EMG nerve conduction study, which is a two-part study. So the first part is where you're sending electrical shocks in different areas of the arm and measuring how fast the nerves conduct to see if there's any slowing of the nerves. When we tested all of her nerves, everything looked perfectly normal. That's why you do the second part of the test, which is the EMG, or the needle portion. The needle part is using a very fine needle, sticking it into the muscle, measuring the muscle activity, and then having the person contract that muscle to see what kind of power is generated. From that study, we concluded that the problem was really coming out of her lower neck area rather than from the arm area.
He says, didn't you have a disc surgery, a disc replacement done a couple of years back? I said, yeah, 15 years ago. And he says, well, which one did you have done? I said, 5, 6. He says, it's your next set.
15 years ago, Sally had injured her neck in a boating accident and had surgery.
I had a herniated disc, and they ended up having to take that out and do a fusion. So they took that out, put a plate and screws in my neck.
The downside of doing the fusion is then the level above and below have to work harder. They actually move more to keep the same motion in your neck. So you don't lose any motion in your neck, but the level above and the level below are going to actually move more, and that puts them at risk to wear out and have the same problem, which she had, another disc herniation, and pinching the nerve, or in her case also pinching the spinal cord. With the nerve being pinched caused the pain and the numbness down her arm, and with the spinal cord being pinched, she felt that weakness or clumsiness or inability to grasp objects with her hand.
The plan was to do a disc replacement with this very small metal disc.
I was okay with it and anxious to get it done and over with and get back to my life.
So for her surgery, first she had a little plate on from her previous surgery to get the fusion. So we took that plate and screws out to get access to the level below. And then the level below, we took out the middle 2/3 of this disc, and that allowed us to decompress the spinal cord, which is in the back here, and the nerve root, which is coming out here. And then for the opening that was left, we have a disc replacement, which basically fits right in there. We're able to cut a little keel in the bone, and it press fit right in there.
After everything was over, he came out and told me that everything went fine.
Sally could feel the difference almost immediately.
When I woke up in the hospital and I asked for the ice chips and everything, I didn't think twice about it when I picked up the styrofoam cup. I just picked it up and, took the ice.
She grabbed it, and she grabbed it with one hand, which she hadn't done for months. I said, well, I guess it worked. You're holding that cup with one hand.
A significant improvement that is noticed every day.
She has, full use of her hand and no issues, like nothing ever happened. It's giving her her life. She can do what she wants to do.
I feel great today. Back to myself, have strength in my hands again, can lift, can paint, can hold a pencil, hold a glass, do everything I used to do.
And Sally says the most difficult part was after the surgery, when she had to take it easy and rest and relax. After 6 weeks, she was good to go. Back to you, Chuck.
Thank you, Deborah. And joining us on this set right now, Dr. Mark Knob. Doctor, what types of spine conditions, we talk about surgery, let's begin with the basics here. What type are typically treated with surgery?
Best reasons to do surgery really are people who have nerve compression or spinal cord compression. So herniated discs, spinal stenosis, either in the neck or the low back, those are the most common procedures that we do.
Now, when somebody talks about spinal surgery, it can be very scary. What do you tell your patients?
I tell them any surgery on their spine is a major deal. Some of the stuff that we do is relatively small, and the risks are pretty small. Some of the surgery that we do is pretty risky. So try to be honest with them and lay out what the risks are and what the potential benefits are.
Let's talk about the benefits. What are some of those you might see?
Well, hopefully we're going to make their symptoms better. That would be the major one. If they have nerve pain in their arm or in their leg, decompressing the nerve hopefully will take that away. We can hopefully decrease their pain and increase their activity as a result of that.
Now, do you have a graph that says, okay, this was successful? How do you determine if surgery was successful, and what is the success rate?
Well, the success rate for each individual surgery is variable. If you take surgeries that are aimed at decompressing the nerves of the spinal cord, success rates are 80, 90, 95%. If you take surgeries that are aimed at, say, fixing low back pain, the success rate is actually quite lower at, say, 50 or 60%. Success is determined basically by the patient. If they feel better, if their pain is less, that's a successful outcome.
That's when you can tell by their face.
Exactly.
Now, with surgery, there's always risk. There are all kinds of risks. Talk about the risks in spine surgery.
Well, aside from the risk of general anesthesia, which anybody has when they have an operation, risks of spine surgery, most catastrophic would be some sort of neurologic deficit, so a spinal cord injury or nerve root injury. Thankfully, those things are very uncommon. Infection is a risk. And maybe the most troubling thing is when someone's symptoms don't get better. And again, it depends on what type of operation you're doing in terms of what the likelihood of success is.
Sure. Now, talk about the surgical treatments that are offered at the Spine Center. What are some of the treatments?
The good thing about our Spine Center is that we really have comprehensive surgeons that can provide comprehensive care. So we really can take care of deformity and trauma and tumor and infection, and then really any of the degenerative conditions that people present with, spinal stenosis, disc herniations, things like that.
Is there a set recovery time for this kind of surgery? And what about rehab playing in there too?
So some people require rehab. The larger the surgery, the more likely that is. The older the patient, the more likely that is. Some of the smaller surgeries can be done as an outpatient, and the recovery is only a couple of weeks long. Some surgeries take 6 to 9 months to recover from.
So quite a range.
Yes, really depends on the magnitude of the operation.
Sure. We're going to break right now and check back with Deborah Pinkerton in the ABC 27 call center. It looks like you're very busy over there, Deborah.
They really are, Chuck. A lot of people have questions about their back, about their neck. The number to call is 717-346-3333. Here to answer our first viewer question this evening is Dr. David Giampetro, a pain management specialist at the Med Center. Thanks for being with us.
Thanks for having me.
This is the first question. I'm 59 years old and I have sacroiliitis along with degenerating discs in my lower back. After any type of physical activity, including walking, the next day my sacroiliac joint will go out and it's extremely painful. I've gone through physical therapy and exercise daily, but it has not helped. What are my options?
Well, the first thing I would say is that if someone truly has inflammatory sacroiliitis, they would want to see a rheumatologist to be certain they don't have any of a few rheumatologic conditions that can cause that. After that, more specific treatments for sacroiliac pain would include physical therapy, wearing a brace during activities that aggravate the pain, getting a sacroiliac joint injection, and even considering a sacroiliac joint denervation procedure.
Okay, thanks so much, Dr. David Giampetro. Once again, the phone lines are busy. If you can't get through, you can email your question to questions27@abc27.com. We will be right back.